Good evening. I'm Prashanthi Thota, Director of Esophageal Center in the Department of Gastroenterology and Hepatology at Cleveland Clinic. The name of this article is Prediction of Neoplastic Progression in Barrett's Esophagus Using Nanoscale Nuclear Architecture Mapping, a Pilot Study. This study is a collaboration between various departments in two institutions, the Departments of Gastroenterology and Hepatology, and also the Department of Pathology at Cleveland Clinic, and the Division of Gastroenterology, Hepatology, and Nutrition, the Department of Bioengineering, and the Department of Computational and Systems Biology in the University of Pittsburgh. What is Nanonam? Nanonam stands for Nanoscale Nuclear Architecture Mapping. Nanonam measures the submicroscopic manifestations of alterations in the intrinsic three-dimensional structural architecture of the cell nuclei in unstained formalin-fixed paraffin-embedded tissue sections with nanoscale sensitivity. What it measures is the intrinsic density alteration of the nuclear structure rather than the amount of stain uptake. In conventional histopathology, we indirectly examine the microscopic nuclear architecture through visualization of stain uptake, as opposed to the Nanonam, which directly quantifies the nuclear architecture of unstained tissue samples through its three-dimensional refractive index distribution. This refractive index distribution quantifies the optical density of the sample and hence its intrinsic nuclear architecture. With Nanonam, we measure the depth resolved alterations in the average local density of the cell nuclei and the localized heterogeneity in these alterations. Of note, Nanonam detects a gradual increase in the density alteration of the nuclear architecture during the malignant transformation. This has been demonstrated in animal models as well as human models of colon carcinogenesis and also in patients with ulcerative colitis, even though the tissue appears histologically normal according to the pathologist. So there are some four main advantages of Nanonam over conventional histology. One is with conventional histology, you're looking at microscopic changes. With Nanonam, you're looking at submicroscopic abnormalities with nanoscale sensitivity of nearly 1 to 2 nanometers before their manifestation at the microscopic scale. The second thing is with conventional histology, we are indirectly measuring the nuclear architecture based on the stain uptake. Whereas with the Nanonam, we are actually getting direct measurements of the nuclear architecture. And the third one is with the histopathology, there is a considerable inter-observer variability in the interpretation of the changes of dysplasia. Whereas with Nanonam, we get objective measurements, so there is less chance of any human error. And also because these changes are detected much earlier, then dysplasia is obvious on histopathology. So we can risk stratify the patients much sooner, even before they develop the dysplasia. So why do we feel a need to do this study? Currently, we are treating only Barrett's patients who have either low-grade or high-grade dysplasia. Most patients with Barrett's esophagus do not have dysplasia, and the patients who develop esophageal adenocarcinoma do not necessarily go through a stepwise progression from no dysplasia to low-grade dysplasia to high-grade dysplasia. So identifying this high-risk patients who are at a high risk for progression to cancer is an active area of Barrett's esophagus research. So if we can identify a patient at high risk, we can intervene early instead of having to make them go through surveillance. In this study, we identified 46 patients with Barrett's esophagus, of which 21 patients progressed to high-grade dysplasia or esophageal adenocarcinoma over a mean time of 3.7 years, and then compared them with 25 patients who did not progress, who remained non-dysplastic or a mean follow-up period of 6.3 years. So we used the slides obtained at the index endoscopy, and the Nanonam imaging is performed, and each nucleus is assigned a three-dimensional depth resolved optical path difference value. Using this drop D value of each nucleus, we computed 12 patient-level Nanonam features, which summarize the statistical distribution and the heterogeneity of the Nanonam-based quantification of the intrinsic nuclear structure. So these 6 values are the mean, the medium, the max, the standard deviation, the skewness, which accounts for the asymmetry, and then the entropy, which corresponds to the heterogeneity of the drop D values of all the nuclei across the lateral direction at axial depths that were 45 nanomicrons apart, nanometers apart. Next, we calculated the mean and entropy in the axial direction, resulting in 12 patient-level drop D statistics. They're the mean, the mean median, the mean max, the mean standard deviation, the mean skewness, the mean entropy, then the entropy mean, the entropy median, entropy max, entropy standard deviation, entropy skewness, and the entropy. These 12 features were compared between the cases and the controls. So those are the progressors versus the non-progressors. And based on the differences in the Nanonam features and the clinical features, we built a risk prediction model using a support vector machine-based classifier. So there was a statistically significant differential shift we observed between the progressors and then the non-progressors. Of the 12 Nanonam features I mentioned before, 6 features, the mean max, the mean the mean median, entropy median, entropy, and the entropy skewness showed statistically significant differences between the progressors and the non-progressors. So the prediction model we built based on these Nanonam features, it identified progression in independent validation sets with the area under the curve of 80.8. And when we combined it with the length of the Barrett's esophagus segment, it increased to 82.5%. So we conclude from this study that Nanonam can serve as an adjunct to histologic evaluation of Barrett's patients and then aid in the risk stratification. What should come next? This is a proof of concept study. Next, we need to examine the Nanonam features in much larger populations, see when these changes begin. Are these changes the same throughout the length of the Barrett segment? In other words, is there a field effect? Can we combine this with now evolving non-invasive screening methods for Barrett's esophagus? Is this cost effective? This is an exciting area of research. It can be easily integrated into the workflow in a pathology lab, and we look forward to evaluating this technology further. Thank you.